morning, everybody. Thank you for being here. We're going to have the first session, which is called Increasing Access to Transplantation. You know, as you may know, when we started here at Downstate, the program was inactive. At that time, a new rule changed. Like, for example, if there's a donor here today, we used to have a 100-mile radius of recipients who are on the list could access that organ. They increased that to 300 miles. So there's more access to transplantation, and how we are, and with other organs, we have pumps, and the way we do the organ referral to the UNOS, and the new rules that are coming where there's another organization that's going to be involved in organ allocation. So the whole journey here is about increasing access to people on transplantation lists, so to have better outcomes and better quality of life. So to start off with, we'll start off with Dr. Rochon, who's our Chief of Transplant, who's been here for the last 2 years. And we've done a great job of doing close to 120 transplants so far, and with excellent outcomes. Welcome, Dr. Rochon.
Thank you so much, Dr. Suresh, and thank you again for being here. It really is my pleasure to discuss this topic today. My assigned topic and something that I'm passionate about is utilization of what we're going to call overlooked kidneys. There are other terms for them, but I think that qualifying them correctly as overlooked is the right way to look at them. Some people call them marginal. Some people call them different names, but I think that at the end of the day, given the excellent outcomes we have with their utilization, I prefer to look at them as overlooked kidneys that have a huge benefit in our community. So I thought I'd show you what an overlooked kidney looks like, because I think that you may think that the overlooked kidney is the ugly girl who didn't get invited to the dance, but I think that these kidneys can be quite beautiful. This is a kidney we just transplanted on March 28th, and it looks absolutely perfect. Look at this aorta, barely any plaque. The donor was 59 years old, smoker, high blood pressure, and alcohol. But the final creatinine before procurement was 0.49, which is perfect, better than me. The KDPI, which is an index that we use in transplant to try and assess the longevity of the kidney, how long the kidney is going to last post-transplant due to donor factor, was 53, which is very good, right? 100% would be the kidney that we think is going to last the least long. So 53, very good kidney. We put these kidneys on pump, and the flow of perfusion solution through the pump is also an indicator in the literature of how long the kidney might last. So the pump flow were perfect, and the resistance was perfect. So again, everything was perfect, but people didn't like this. And this was not a tiny little lady who had a creatinine of 0.4. This was a donor who was 5'11" and weighed 240 pounds. So a creatinine of 0.4 is fabulous in these circumstances. We transplanted this kidney at 23 hours after procurements. Kidneys can be transplanted up to probably 42, 45 hours. Some people have done 48. And our recipient was ranked 2,180. So that's how many other recipients had been skipped for this kidneys. Everybody around in our region didn't think this kidney was going to have good outcomes. So we transplanted it. I think Dr. Finnig and Dr. Suresh transplanted this together, and the patient's doing fabulous, and her last creatinine is 1.2 normal, right? And it worked right away. This patient had been on dialysis for 1 month. And this is what we do here at Downstate. So since our team started to work together with the mission of breaking barriers to transplantation, our mission has been, how do we get access to care to these patients? How do we get our patients transplanted? Where do we find kidneys for them? This is part of what's called the SRTR, so it stands for Scientific Registry of Transplant Patient. It's public data that anybody can access, and it's part of the monitoring that every transplant center is subject to. So if you go on that public website and you look at the latest report for Downstate, you will see this graph under organ utilization. So if you are a poor organ utilizer, meaning you only accept the best kidney you've ever seen for transplantation, the kidneys that we also almost never see, right? The 25-year-old perfect creatinine that somehow had a head trauma, unfortunately, those donors are rare. There's very few of these kidneys, but if that's all you accept, your center's line there would be all the way to the left because you're very conservative. And that's actually where the line was 2 years ago at Downstate in terms of organ acceptance. And the work that we've done has been to find the precious kidneys that we're going to that are going to work in the amount of kidneys that other centers have overlooked so that they can benefit our programs. And that's why now doing this work, our line is all the way to the right. We're among the national leaders, right? Our acceptance rates is 3 times higher than the national median about accepting kidneys that other centers have overlooked. And so for this last report that came out in January, we had 27. This was a report that included 71 transplant recipients, and 27 of those that the offer was more than 100. That means like more than 100 patients had been skipped before the kidney came to us. The offer came to us and we accepted it. And you might say, okay, you accepted it, but are the patients doing well? I mean, are all these other centers wrong to not use these kidneys? And I would tell you, yeah, they're wrong because this is also public data. This is our last SRTR report here at Downstate. And you can see that our outcomes are better than expected. Here, can you see my mouse? We can't. Oh, yeah, you can. So here you can see on the right, you have the graft survival. So the kidney, how the kidney is functioning after transplant. Our results right now at Downstate are better than expected. So again, very good, even if we're accepting kidneys that other centers have overlooked. And our transplant rate is better than expected, and our waitlist mortality is lower than expected. So those patients who are sitting on dialysis and listed with us have a better survival. When you get listed at Downstate, we will ensure that we can get you transplanted and care for you in a way that the mortality would be lower than what is expected for patients waitlisted on dialysis at other centers. And a lot of that has to do with the fact that we give them access to care and access to transplant early. And of course, we have a great team. So when we look at the current kidney allocation, so KAS, the kidney allocation system has been revamped in 2014. And the revamping of it, the goal was to move more towards a longevity matching sort of allocation. And so the basis for that was that, like, when I was a fellow, which is not that many years ago, but when I was a fellow in transplantation, I remember transplanting one time, transplanting 6 months old kidneys into an 80-year-old. And the 80-year-old did great for the 6 months old kidney with the transplant. And about 6 months after transplant, had a massive heart attack, which a lot of 80-year-olds do get, and passed away with a perfect creatinine. And so that is not a good example of longevity matching, right? Kidneys that could last 50 years were given to somebody who had already exceeded the national life expectancy. And so the idea of giving the kidneys that will last the longest to those who will live the longest was the idea here behind the revamping in 2014 of the allocation system. And so the kidney community, the transplant community, developed these scores. So on the patient side, the score is called EPTS, expected post-transplant survival. And on the donor side, it's called the KDPI, the Kidney Profile Donor Index. So both are trying to, both these scores are trying to assess how long the patient's going to live, how long the kidney's going to last, and give the kidney that's going to last the longest to the patient's going to live the longest. So here, this is all the data that is included in the KDPI, so the donor assessment. So when we have a deceased donor, all of these data have statistical weight, and then it's put into a formula and you come up with a score. And then again, that score is translated into the percentage of kidney allocations that are we think that are the 20% longest longevity and so on. And so you can see here on this scale, you have the 1 year and 2 year estimated graft survival following the index score. And what I want to point out here is that even the worst of these kidneys, the one with the highest score, still has a 76% 1 year survival. So 76% of the patients who get transplanted with the worst deceased donor kidney out there by these criteria, 76% of them still have a functioning kidney 1 year after transplant. So that is important to realize. So these kidneys are not terrible outcome. 76% of patient off dialysis is a big win. But that 25% risk of losing that kidney, that's where the transplant community get worried about utilizing them. So that's the score that we get for the donor. And we get that at every offer that we get. The kidney is matched with such a score and to help us assess which patient would be better. And the allocation algorithm, which is all computerized, is also takes this into account. And then here is the EPTS, so the expected post-transplant, estimated post-transplant survival. So we're trying to see how long from the data that we have do we think this patient will be able to enjoy this kidney. And what goes into the score is the age, the length of time on dialysis, whether or not they had a prior transplant, and whether or not they have diabetes. That's it. No other factor fills the EPTS score. And so with that in mind, the latest figures on organ utilization are clear. Here at the bottom, you can see you see a rising line, and that is all data collected. How many kidneys are procured every year? And you can see that that line is rising. So every year, the OPOs, which are the organ procurement organizations, are procuring more and more deceased donor kidneys in the community. I think that the awareness to transplantation is rising. The donation rates from our community member is rising. And so because the community, there's such a big need on the wait list, and there are centers like us who will be ready to utilize most of these kidneys. Those OPOs have an incentive to procure more and more of these kidneys, sometimes from older or more or patients with more comorbidities like high blood pressure and some diabetes, as long as the kidneys are working. So they have an incentive to procure more donors. There's more procured, but the sadness is there's also a lot discarded. So the graph here to the right shows you how many kidneys are discarded every year. And those that are the most discarded are here in green, which are the kidneys from older adults. So those kidneys are often the ones that have that highest score. And that highest score is often the one that's also matched with patients who have either been longer on dialysis or have been or older. And so to discard this kidney affects directly a subset of patients who it would also benefit from them a lot. And so how do we as a transplant community make sure that we move more towards being able to transplant these kidneys into the right recipient, lead to less discard of precious organs, and increase access to care is one of the missions we've given our program. So delayed graft function, one of the things that we are lucky to have here is we have very strong nephrologists, both sitting here in the first row, who sort of like, the surgeon works for 3 to 4 hours, and then tag urit, the nephrologist works for 1 month after the transplant, working with us, because as we increase the acceptance of these kidneys that have been overlooked, a lot of them have been on ice for a long time. Some of them, the donor was in shock a little bit, and so the kidney remains in shock post-transplant. And what delayed graft function means, it means the kidney doesn't work right away, and the patient needs some dialysis within the first week of transplant. So We believe at Downstate that if the kidney worked before, it will work after transplant. But to provide excellent medical care to those patients right after transplant, when the kidney doesn't work right away, to keep them well until the kidney wakes up, is where the key to success to increasing organ utilization is. When you're able to transplant these patients, utilize these kidneys, and have good outcomes despite the fact that the kidney didn't work right away, that's the key to success. That's the key to increasing utilization. And so very recently, and Dr. Suresh just alluded to it, we had another change in the kidney allocation because a lot of the disparities in access to care that were addressed with the revamping of the allocation system in 2014, one of the remaining one was geographic disparities. So there were still areas in the country that had less access to care than other. One of them was New York City. And so now kidneys are allocated primarily within a radius of 250 miles from the donor hospital. And so New York City is within 250 miles of a lot of other cities. And we have the longest list and the most dialysis patients in the area. And so it's created, since this allocation went into effect in the second quarter of 2021, a lot of kidneys coming more to New York City because of this revamping in allocation. There's a lot of criticism about this revamping of allocation. A lot of people are thinking that a lot of kidneys are moving a lot more or being transported a lot more than they were before, which is leading to all sorts of other things. So this graph here shows you in the dotted line here, you have the kidney discarded, right? So unfortunately, there's been a rise in the discard of kidney, as we discussed, and the change in allocation system has not stopped that trend. So with this change in allocation, the increase in traveling leads to increase in cold ischemia time, which means the time the kidney spends on ice, the time it takes for the kidney to get to the center where it needs to go to. And so that's the line that you see here in pale blue. So that is rising, right? So because we're transporting kidneys more, they're going further away than they used to be from the procurement hospital. It increased the time that the kidneys are spending on ice. We're not seeing a change in outcome with that. And that's because we have a lot of improvement in the organ perfusion domain that is helping us keep the kidney in good status despite the rise in cold ischemia time. But what you see here with this rise in cold ischemia times is exactly where our opportunity or where our work has been here at Downstate, is that here is where we are increasing utilization of overlooked kidneys because we are making these kidneys work in the right recipient at the right time. Who benefits from this kidney? Who can we say this is going to be a good kidney for these recipients? How do we know that there's an increase in how do we know that increasing utilization is also beneficial to our population? This is a very nice study published in JAMA 2022. And what it shows here, this graph may look a little bit complicated, but that orange line up here is showing you the increase in survival within 5 years and then within 10 years of transplant compared to staying on dialysis. So for all as the patient age ranges. And you can see here you have the survival benefit. And so the very young patients can probably afford to stay on dialysis a bit longer to wait for that perfect kidney, because another year on dialysis doesn't change their longer survival that much as long as they do get transplanted eventually, right? But the older patient have a huge rise in survival benefit from getting transplanted because dialysis in them is harder. The risk of having fatal event or complications of dialysis rises. And so the benefit of transplant in terms of survival rises sharply for patients north of 40. And that benefit in survival remains even north of 70. It just isn't as much as it is when you are 60. And that is fine because, you know, these patients are, again, nearing normal life expectancy. So the survival benefit isn't as great, but it's still there. And it's even bigger 10 years post-transplant. So patients of all ages have survival benefit from getting transplanted, especially patients north of 40. And this graph here is saying the same thing, but it's by dialysis time. And so although this may look complicated, you can see that the patients who are more than 2 years here, patients more than 2 years on dialysis have the sharpest long-term survival benefit from getting transplanted compared to staying on dialysis. And I think that's really important because that's at the heart of what increasing utilization of the overlooked kidneys benefits our community. This is a very nice study, I think, from, so we just established, so older patients, all patients have survival benefit from getting transplanted, and especially older patients, right? So done, check mark. Here, another discussion is, what about patients of any age but with low functional status? And on dialysis or wherever you work, you see those patients, right? The patients who is disabled, needs a wheelchair. And so this is an analysis by Kronofsky score. And this is a nice study from Northwestern. And what they showed here is the survival benefit of getting transplanted in relation to the Kronofsky score. So to the left, you see the hazard ratio of treatment choice. And you can see, so this blue line here is patients with the lowest Kronofsky score, so the most disabled patient, 10 to 40. I mean, a 40 Kronofsky score is a score of somebody who's disabled, like 10% is bedridden. So 40, these are the lowest functional patients referred to transplant. And even for those, when you compared choosing dialysis versus choosing transplant, providers are choosing transplant more. And then you can see as the functional status rises, of course, it favors less dialysis and more a treatment choice of transplant, obviously. But even the most disabled have a tendency to be referred for transplant more. And then this graph is extremely important because what you see here is for all functional status. And this year, again, 10 to 40 is the least functional patients. All kidneys from 0 to 90, from an index, a KDPI of 0 to 99, they all have a survival benefit. This dotted line here is the survival patient on dialysis. And this pale blue line is only kidneys with a KDPI of 100%. So that worst kidney that I showed you, the 100% KDPI, if you transplant that worst kidney that you can find into the patient who has the least functional status that you can find, they will have an equal survival benefit to dialysis. And what that means is then they will still get all the benefits of lifestyle adjustment, diet adjustments, the opportunity to travel, and have the same survival benefit. And if you give them any kidney that's slightly better than 100% KDPI, they will also have a survival benefit. And so this basically tells us that transplant benefits everyone. Well, does it really? And that's that's what's up for debate. So I think that the challenge we have is we know the patient will do better if they get transplanted. And the art of the trade is in finding out who might not survive the surgery. So when the transplant team meets every week, that's our challenge. How can we assess that the burden of the medication or the stress of the appointments or the stress of the surgical procedure itself, which patient will that be too much for? But everybody else will gain a benefit from getting transplanted. So it's pretty clear that kidney transplant recipients live longer than those who stay on dialysis. They live better than those who stay on dialysis. They have better cardiac function and they have better mental function, right? They can do their Sudoku faster. And so in the transplant community, there's a big discussion about not just survival benefits of transplant, which are predictive life years increase, this old LYFT idea, which is behind the reform of kidney allocation in 2014, but predicted quality adjusted life years, or QALY. And those are very important. I mean, that's where the world is going. People live longer, they work later, they want to be functional to go travel wherever they can when they're retired. And they want their transplant when they're north of 70. And when I'm 75, please transplant me. Right. And so then the whole loop comes back to access to transplantation. Right. We want to transplant more patients. OK, and I still have a couple slides, not that many slides, but we want to transplant more patients. But how do we give them access to a rare resource when we believe that they will benefit from it? So there is currently an increase. So this is from, again, the national SRTR data, and it shows that all of the referral for transplant are pretty stable, except the elderly patients. So the rise, like the 65 plus, is the fastest growing referral to dialysis group age. And the transplant centers who will figure out how to transplant these patients well will be the leaders in the field. This is our data here at Downstate, again, part of that SRTR. And I just want to point out here, so our list is made of 80% African-American patients. So patients who have been struggling with access to transplantation in the past are getting listed at 80%, a lot more than our region, which is at 32%, or the nation, which is at 29%. Also, the age, you can see that on our list right now, we have a lot more patients north of 65 than our region or our country. And so behind, so this is the data that is behind, to show you that data is behind what we do here. And this is, you can see NYDS, that's our sender code for the, so these are our data. We put our money where the mouth is. We are actively increasing access to transplantation to this population at our center. But are we really, is really putting patients on the wait list the solution? Well, once you put them, you've gained their trust, and then you owe them to get them transplanted. And this is, again, national data that shows that 10% of the list every year drops out. They're either too sick to get transplanted or they die waiting. So that's 10%. And every year we have about 100,000 patients on the wait list in this country. So 10% is a huge amount of patients who just don't make it to transplant because they got too sick. Transplanting them earlier increases their survival. And this is, again, where the mission of utilizing overlooked kidney becomes important. This is a very interesting study made by Europeans, but looking at American data. And what you see here is that this is patients who died on the wait list, and they died on the wait list. Meanwhile, they had received numerous offers. And this study excluded offers of kidneys who got discarded. And we know that a lot of the kidneys that get discarded would have worked. And so as the patients, there is a rise in refused offer for a kidney and patients dying, which makes you think that refusing a kidney that you're being offered, if somebody else is able to transplant it successfully, it has survival implications for the patient. And those waitlisted at conservative centers really have a higher chance of death on the waitlist, is what it comes down to. And the literature is very clear that the number of times a kidney is declined by transplant center is unrelated to its long-term function. So why not accept all offers? Well, this is the downside, right? So this here shows you if you have a patient who gets a transplanted kidney and it has early graft loss, a loss within 90 days, either it never works or it doesn't work well and gets lost within 90 days. These patients' survival is a lot worse than those whose kidney work, all right? So that's the downside. And a lot of the patients who lose the kidney within 90 days, only about 15 to 20% of them actually make it to get relisted for a second kidney, unfortunately. And so that's the risk. If you were wrong, that patient's survival really drops from being transplanted, but hold on here, their survival is the same as those who remain on dialysis. And this is this image from this famous 1983 New England Journal of Medicine a paper that finally showed that transplant was better than dialysis. So I just put that for historical data, but it's important to realize that. So of course, if you were wrong and this patient loses their kidney early, they don't have the same survival as if they waited longer for this perfect kidney and they got transplanted successfully. But their long-term survival is not different than if they stayed on dialysis. And this is a very good paper here on the right, just key points by Dr. Andrioni, who is at Case Western, and he's in Cleveland, and he really criticizes the federal oversight of transplant centers, showing that to constantly nag centers for 1 year survival and be on their case whenever there is a graft loss leads to decreased utilization, which makes centers afraid of transplanting patients, and then people die waiting. This is at the heart of increasing allocation, increasing access to transplant, increasing access and utilization of the overlooked kidneys, and letting transplant centers just really save lives. It's a paper by Doris Segev in 2014 that showed you that whenever regulatory agencies nag a program, the transplant rates go down and the access to the organ utilization go down. So why should we utilize overlooked kidneys? So really an organ suitability should really be taken into account in relation to that one patient and not all patients. Increasing or offer acceptance rate leads to our organ OPO or OPO's organ procurement organization increasing the procurements of organs, which then increases access for sure. And we need to continue to sustain that. And we need to work as transplanters to make sure that the allocation and the regulations are well balanced so that our patients have access to care. And that the beneficence, the good that we do, and the principle of do no harm are well balanced so that our patients really get the true benefit of transplant. And here, this is a picture of our outstanding team, and you'll see most of them through the day. And I thank you for listening to us.